Hi, this is Eric Dein from New Jersey here at ACR Convergence Day 2. We just wrapped up a great day, and I'm here to talk about some of the oral rheumatoid arthritis abstracts that were just presented. So we had a wonderful afternoon session where one of the things that we talked about, the first abstract was 1743, which looked at the difference between low disease activity and remission. The goal is we love having patients in remission, but from the guidelines we often say that low disease activity is good enough, that we got them pretty close and we don't need to up-titrate their medicines to the highest degree. But is there a difference between LDA and remission? The study looked at LDA, which is again that CDAI less than 10, remission less than 2.8, and they also had another group of very low disease, which is between the 2.8 and 6, kind of the lower part of the very low disease. What they found is that particularly when you look at that higher level of the lower disease activity between 6 and 10, the patients did not do as well as those patients in remission or very low disease activity. They were not feeling as well. Their patient-reported outcomes, their fatigue, their pain were notably higher. It's not a surprise, of course, that they're not quite as good, but it did have significant impacts, and it showed that they were utilizing healthcare more, they were using ambulatory devices like canes more, and so this is a suggestion that says maybe we should have a little bit of a higher target, maybe we should be going for a little bit better disease control, if not remission, maybe a CDAI of under 6 for a very low disease control. So I think that is something that we can change our practice with and take into account when we see someone who's kind of has that CDAI of 8 or 9 doing kind of okay, but maybe not well enough for what we want. The next oral abstract that came just afterwards was 1745, which was taking a look at the oral surveillance study again. So we've talked about the oral surveillance a lot over time. They did another post hoc analysis, but I think this one really adds a little bit more color to what we've heard. Of course, with the oral surveillance, we know that the main takeaway was Tofacitinib was not non-inferior to TNF inhibitor, that JAK inhibitor showed that there was the higher MACE events. One question they had, though, is what if we specifically look at statin usage? Does that make a difference? And what was interesting was, first of all, at baseline, there was not enough statin usage in the group. Only less than a quarter of patients were using a statin, and of patients that had the known risk factor of MACE events, it was 50% of them. Half of them were not on appropriate treatment for someone who has had a history of a MACE event. In the patients that were on a statin, they did as well as the patients on TNF, regardless of if they were in the TNF or TOFA category. So that provides some reassurance to me that if you have a patient that has been doing well on Tofacitinib and they're worried about their MACE risk, then maybe you can still do it as long as you're doing the other preventative things well, or secondary prevention by having them on a statin, for appropriate care. And this is something that I think is helpful, gives some more information as to why patients may not do as well on the TOFA. Again, they weren't on the appropriate background therapy with a statin, and so there's always more information we can glean when we go into those numbers from the oral surveillance. So I thought those were two of the highlights from that oral session, and a lot more that me and my colleagues will be having on Room Now.